Hello, everyone. Good afternoon. It's great to be here with you guys. And we have Gültekin Hoca online. We have Serdar Hoca online from Canada. Welcome, all of you. I would like to give word to Gültekin again. We cannot hear you.
Diğer kanalı koydular herhalde arkadaşlar.
Can you hear me now? Yes, yes indeed. Hello everyone. As there is interpretation services, they asked me to speak in Turkish, and I don't know what is the crowd in the venue, and I really wanted to be there because there will be quite interesting information and there will be discussions over the things that we are not completely knowledgeable. I do really wonder this situation. So without any further delay, I would like to invite our speakers, if it is fine with our co-chair Mihriban. It's over to you, and could you please introduce yourselves before proceeding with your presentation? The floor is yours, Mihriban. Thank you. We will start with Serdar. Is Serdar online? He has a video record.
Serdar Dursun. He's a clinician, educator, and researcher who has made significant contributions to translational neuroscience and psychopharmacology. He has over 150 peer-reviewed articles. He lives in Canada. He was going to be here, but unfortunately he's not here, but he will be with us online this way.
Yes. Merhabalar.
Hello everyone. In today's presentation, I will be talking about medical cannabis, and we will be discussing the truths about that. We will be talking about side effects, and the area of use and the legal status in Canada will be presented. As you do know, this chemical material known as cannabis exists as sativa, indica, or in hybrid form, and as marijuana from dried leaves and flowering heads. It is isolated, and there are more than 400 chemical compounds isolated. The most important two groups, as you can see, cannabinoids, and cannabinoids are over the number of 70 types, and there are also non-cannabinoids. However, in cannabinoids, we do see delta 9 THC, delta 8 THC as psychoactives, and there's another group which is psychoactive but non-euphoric, and it is called as CBD, cannabidiol. We have stated that earlier, and other speakers have stated already. The delta 9 THC tetrahydrocannabidiol is considered to be responsible for most effects of most psychoactive, less therapeutic type. We have also cannabidiol. We have cannabis sativa, cannabis indica, and cannabis, the hybrid form as well. Let's continue with the studies in the UK from London. we have this study published in 2015. The ones using 16% THC, 3 to 3 times in a week, which is also called as skunk. There's a high potency risk, and psychosis risk increase 3 times if there is occasional use when we compare it with the non-users, and daily use increase the risk 5 times more than non-users. This is a published study. Surely, not everyone experiences cannabis-induced psychosis, especially in adolescents who smoke cannabis. COMT gene have been studied. If there is VAL in this gene, then it is probable to have psychosis related to cannabis. So there is a genetic effect in relation with COMT gene when we check the psychosis situation. And what kind of other side effects we can list? Unfortunately, cannabis decreases IQ. If youngsters use it from their early ages, if they use it, for example, in the ages of 25, 30s, it is definite that there is a decreased level of IQ. This is a severe problem. And when we check the systemic studies, cannabis use and change in IQ. Other than that, neuropsychological deficits are observed in users. Attention deficits, memory disorders are observed in the realized studies. And what are the side effects? It causes anxiety, especially in adolescent group, and the ones under the age of 30, anxiety is observed. Depression rates are quite high, suicide rates are high then again, and classically we do see a motivational syndrome in 60s especially. It causes amotivation. Sitting idle is the situation that we have observed in these people. There is a decreased balance, sleep disorders observed as well, and immune system response unfortunately decrease. And then again, cannabinoid hyperemesis syndrome is observed. Vomiting occurs because of a potassium decrease. And such severe clinical presentations are observed. In Canada, it is legal now in a very, this is another important situation. Traffic accidents, the use of cannabis decreases, impairs attention, working memory, coordination, reaction time, and visual perception. So there is an increased rate of traffic accidents. So we need to be careful about that. And I believe other colleagues have stated this. What is the mechanism of action? In 1964, tetrahydrocannabidiol have been isolated as delta 9, and then after, cannabinoid receptors have been found as CB1 and CB2 in 1988, and this area have been explained scientifically and got certain attention. Cannabinoid receptors are located throughout the brain, and indeed all kinds of development and cognitive functions affected for brain development, memory and cognition, motivational systems, and rewards. It is important for appetite. It is important for immunological function. Also for neurological issues and pain regulation and analgesics, it is crucial. As I've stated, there are two different receptors of cannabinoids, CB1 and CB2. Generally, CB1 occurs in brain, but other than brain, we do see it in adipose tissue, in muscles, in liver, in gastrointestinal tract, and pancreas. CB2 is seen in immune system generally. THC should be paid attention, especially for antidepressants, SSRIs and TCAs. It could interact for NSAIDs, for beta blockers, opioids, anticholinergics, caffeolines. There is interaction in terms of pharmacokinetics. Of course, when we check DSM-5, what are the diagnostic statistical manual of mental disorder in relation with cannabis use disorder, cannabis intoxication, cannabis withdrawal, other cannabis-induced disorders, unspecified cannabis-related disorders. So, these are the cannabis-related disorders listed in DSM-5. And it has been stated in DSM-5. And when we check the history, in 19th century, cannabis was used across the world for the pain and vomiting. And with the modern pharmaceuticals, there was a decrease in use of it. However, in the 60s, it was identified as illegal. Then after, with the exploration of receptors, youngsters rediscovered cannabis and they have started to use it in recreational form. Then there was a decrease because of the legal status of it, illegal status of it. However, we do see there is an increasing rate. In epilepsy and multiple sclerosis studies, we do see there is an increasing interest in the field as well. Since 2018, it is legal, and the purpose is to keep cannabis out of the hands of youth, keep profits out of the pockets of criminals, collect taxes from the sales point, and to protect public health. So it is legal now, but in which terms it is legal? Everyone may use up to 30 grams of legal cannabis. They may exchange it not as in trade form, but they may just give it to another person. And then again, up to 4 cannabis plants per residence for personal use could access. It is allowed. So the important impact is the aim of protecting youth. It is illegal to sell or provide cannabis to people under the age of 18. And medically, and are there any medications including these receptors? Yes, there are. Sesamet, for example, which exists in Canada, there is Nabilon, and its indication is for cancer treatment, for nausea and vomiting associated symptoms it is used. It has FDA, HC approval in some EU countries. Also, it is used. Marinol is another drug containing dronabinol. It is synthetic THC for AIDS and for cancer treatment. If the patients lost excessive weight, then Marinol could be used for the treatment. Sativex is another commonly used one, and Sativex is also plant-derived and used in spray form orally or under the tongue. You may use it generally for the muscle spasticity related MS. It is indicated. Epidiolex, also plant-derived. This is very important. Why? Because it is approved by FDA. It only contains a pure cannabidiol. Two severe neurological syndromes, which are Lennox-Gastaut syndrome and Dravet syndrome, causes epilepsy, are indicated for this one. FDA approved it. It is not approved in Canada, in EU or Turkey. I believe that this is the most important cannabis product. Let's check data. Cannabinoids as antiemetics. How does it work? I believe it is not quite strong in terms of evidence. It is somehow poor. We need further studies for cancer patients, cancer treatment patients. Nausea and vomiting associated symptoms could be treated with cannabinoids as antiemetics. And as for stimulating appetite, in AIDS, for example, it could be used. Then it requires further studies, but in some countries it has been approved already and in use. Another important field, strength of evidence is moderate. Muscle spasm in patients with multiple sclerosis. Sativex provides good results. And for neuropathic pains, chronic non-cancer pain, cannabinoids are used generally, and the results are positive. For palliative cancer care patients, it could be used, but the evidence is insufficient. I've stated that earlier. This is the most important one approved by FDA for intractable childhood epilepsy, for Lennox-Gastaut syndrome or Dravet syndrome. Traditional epileptic drugs can't treat the epileptic episodes, but this contributes to the symptoms, and it is pure cannabinoids. And other than these, though it is legal in Canada, if you are required to prescribe cannabis, there are strict rules to follow. For example, for anxiety and or insomnia, it is not recommended. Let's check it. I believe there are nearly 15 recommendations, warnings in Canada for clinicians, and College of Physicians and Surgeons of Alberta has a publication over the use of cannabis for medical purposes. There is a standard of practice. The side effects should be taken into consideration seriously for the treatment of patients, and the treatment regime should be reviewed and followed meticulously. And thank you so much for your patience.
Where he is. I think we cannot get questions about that, but I would like to introduce our next speaker. This is Andrew Greenshaw. Most of you, maybe all of you know about him. It's a great privilege to introduce you, Andrew. He's a professor of psychiatry and neuroscience and currently serves as associate chair for the Department of Psychiatry at the University of Alberta. He recently returned to the Department of Psychiatry following 2 terms as Associate Vice President for the University of Alberta. A member of the department since 1986 and a full professor since 1996. He is the author of numerous peer-reviewed research papers, reviews, chapters, books, and continues to engage in research, teach, supervise trainees. He is co-chair of Alberta Addictions and Mental Health Research Partnership Committee. Welcome.
Thank you very much, Yvonne. It's a great pleasure to be part of this symposium today and to follow my good friend, Professor Serdar Dursun, who is, I think, in Edmonton today in the snow. We had 20 centimeters of snow yesterday, I think. So I usually like to start with an indication of something about where I live. And so the first 2 slides are actually scenes from Canada. This is a scene collage of Edmonton, showing downtown Edmonton during the day and in the evening. And then there's a snow hill in Edmonton during the summertime, and this is one of the bridges, of many bridges across the river. And here we are, summer and winter in the mountains outside. On the ski panel, that's skiing at Lake Louise, and the waterfall is Athabasca Falls. That's very beautiful. So come and see us if you can, hopefully after COVID. Western Canada is very beautiful. So I'm talking today about vaping. A lot of people see people vaping. Vaping is seen as less dangerous in the general public view. It's seen as less socially problematic because many of us who do not smoke do not appreciate cigarette smoke. And so vaping takes away a lot of the noxious smells and fumes. But is it beneficial or is it a problem, and how far does that problem go? The cover of Time magazine, September 2019, the new American addiction, how Juul vaping devices hooked kids and ignited a public health crisis. A few small disclosures. We're supposed to disclose things. So advisory or governance board membership for a number of entities. 2 of them are companies that are involved in psychedelics, Midocin and Entheon. I sit on the advisory board for Entheon. I'm a member of the board of Addiction Treatment Center, and I've had funding from industry and from federal and provincial agencies in Canada. And part of the Computational Psychiatry Group, the Digital Hub for Mental Health, and also a new interventional psychiatry group at the U of A. So, Johns Hopkins would like you to know 5 facts about vaping. What I thought I'd do with this talk is I'd take a bird's eye view. Here we are at a scientific congress. It's really important if we look at the public health messaging that goes out there and what people normally see. So this is the public face of Johns Hopkins. 5 vaping facts you need to know. 1, vaping is less harmful than smoking, but it's still not safe. 2, research suggests vaping is bad for your heart and lungs. And in here, the Center for Disease Control recommends that people don't use THC-containing e-cigarette or vaping products. Avoid using informal sources for vaping equipment and contents like friends, family, or online dealers. And don't modify or add any substances to a vaping device that are not intended by the manufacturer. So there were early problems with vaping devices. They would overheat, some of them would explode. The technology has settled down, is a lot better, but there are still safety concerns. So they're the first 2 things that Johns Hopkins wants you to know. The second two things are electronic cigarettes are just as addictive as traditional ones. That's not widely known by people, but the evidence, as it is, illustrates that. And electronic cigarettes are not the best smoking cessation tool. A lot of people talk about vaping as an alternate that may be more healthy and may be an enabling way of allowing people to beat nicotine addiction. But the evidence doesn't really support that. The last one, Sudha mentioned the problems of youth and drugs. The last one is a new generation is getting hooked on nicotine. This is really interesting because there have been lots of nicotine use decrease, public messages going out, nicotine substitution with non-contingent nicotine stimulation with the patch, and drugs to attenuate craving. But in fact, it looks like these vaping devices have increased nicotine intake in kids. So looking at Canadian data, again, this is from a study that was done, a Canadian study, reported in the national news agency, Canadian Broadcasting Corporation. Canadians aged 16 to 19 who reported vaping in the previous month, when they checked that out in 2017 and compared it to 2019, it went from 8.4% to 17.8%. So it doubled in 2 years in terms of the number of kids who are vaping, and that's for nicotine. StatsCan is a great national source. They collect all kinds of statistics. They don't interpret things usually, but it is what it is. It's a national survey released in March of 2020. And there are two tables from this that I'll show you. This one is age, and they say gender, but they should know better. This is actually biological sex, not gender. It's men and women identified at birth as such. Life is more complicated than that these days. But if you look at the histograms, don't worry about the colors of the bars. You can see that all ages, it's around 5%. For 15 to 19-year-olds and 20 to 24-year-olds, it's above 15%. And 25 or older, it drops below 5%. So the people who are reporting vaping in a national survey tend to be young people, and most of those are vaping nicotine. If we look at sex effects, it says gender, but it's really sex effects. It affects both men and women. There are some slight differences. You can see 20 to 24-year-olds, there are more men than women as a percentage reporting vaping. But it's a substantial proportion of both sexes. Neither men nor women are avoiding vaping in Canadian data. And this is an interesting piece put out by Tobacco 21, which is an anti-vaping message. One has to be really careful in what is legal drug use of the kinds of messaging that comes out and what the bias is. So you can imagine that the cigarette manufacturers might not want vaping to become popular. You might think that some people who are totally against nicotine use might not want vaping to be popular. This focuses on vaping as a gateway to smoking. So these are 9th grade students. They're 14-year-olds. And if they were using e-cigarettes or not using e-cigarettes, how many started smoking within 6 months? So the e-cigarette users, remember vaping is supposed to be a less problematic way of taking in nicotine. 30.7% of those people in grade 9, 6 months later, are smoking. They're either smoking cigarettes, cigars, or using a hookah pipe or water pipe. 8.1% of non-vapers. So vaping is actually promoting use of tobacco products outside vaping delivery, which is a very bad thing. People have tried to draw a parallel to the opioid crisis. I don't think it's a really good parallel. trying it on for a political message, and I think the intent is good. They're talking about the iatrogenic epidemic that was created in Canada and the United States by overprescription of OxyContin or oxycodone, and that leading to harder opiate drug use, intravenous drug use. That clearly has happened. It's a complicated story. It's not really the same for vaping leading to tobacco use. The parallel is there, but I think it's overstated in this case. So vaping is less harmful than smoking, but research suggests that vaping is bad for your heart and for your lungs. And electronic cigarettes are just as effective as traditional ones in that there's an increase in use. We think this is leading to dependence, and then those young kids who are using vaping devices, they are beginning to use other tobacco products. So vaping is a kind of gateway to more traditional ways of ingesting tobacco. There are a lot of discussions about what the health problems are, and you see bits here and there, things like small cell lung disease, different kinds of acute pulmonary damage. So I've given two examples, I think, in this slide deck. One is published in 2021 from the journal Chest, and this is US Centers for Disease Control Prevention data. So vaping can cause acute lung injury. E-cigarette or vaping-induced lung injury, EVALI, most patients were adolescents and young adults. And for a period of a year from 2019 to 2020, patients hospitalized for EVALI, 2,807. That's not a huge number across the United States, but it's significant. And 68 people were attributed to have died due to vaping-induced lung injury. And in February 2020, the Center for Disease Control were overwhelmed by COVID, and they stopped collecting those data. Looking at what happens with e-cigarette impact on human health, comparing e-cigarettes and conventional cigarettes, you won't be able to see very clearly the table on the side of the slide, but there are two columns in the middle that are just plus signs. One is e-cigarettes, and the other is conventional cigarettes. And if you can see those plus signs, you'll see that just about everything for human studies, in vivo studies, and in vitro studies is marked for both e-cigarettes and conventional cigarettes. The only difference is that e-cigarettes, it's less intense. And for e-cigarettes, there are a couple of things missing. That's enhanced interleukin-1 beta and TNF-alpha expression and apoptotic activity. They are absent for e-cigarettes. And also changes in human airway epithelial cells, reduced epithelial barrier integrity is not found in e-cigarettes, but is found in smoking. But basically the same profile, just less intense. And vaping devices, I mentioned this a little bit before, they're associated with risks, not just related to the physical properties of the device, but also related to the aerosol and other components. So in this, the harmful effects come down to respiratory system effects and other effects that include some cardiovascular effects and some carcinogenic effects, because some of the products of pyrolysis in the vaping process, depending on the heat, can deliver carcinogens or potential carcinogens to people who are vaping. How does smoking and nicotine dependence change after the onset of vaping? This was a retrospective analysis of dual users, and it was a smoking cessation study, a trial with just under 3,000 users published in 2020. They measured nicotine use frequency and heaviness of smoking index, and they compared pre- and post-vaping number of cigarettes per day and combustible cigarette or e-cigarette dependence, pre-post-vaping total nicotine use and frequency. The variables associated with greater overall nicotine dependence in this trial included using e-cigarettes for more days per month, having more puffs per vaping session, and using higher So vaping is risk factor. If we look at vaping youth, this is from a public presentation of data by Newsweek. It gets a lot of attention, but is based on a NIDA study looking at vaping prevalence in 8th graders, 10th graders, and 12th graders in the US. So 8th graders are 13, 14, and 15-year-olds. So if you look at last year and the last month, 12th graders are more prevalent for vaping as time goes by. You can see that 8 to 10 to 12 is increasing in each year. So clearly there's an early start and the prevalence increases. One of the saddest things I've seen in the public health messaging, and again based on the National Youth Tobacco Survey, is you go back to 1999, 35% of youth were using tobacco products, smoking in some way, chewing tobacco, smoking tobacco. 20 years of reductions in teenage nicotine addiction wiped out by flavored nicotine salt e-cigarettes. So 2011, the incidence was 1.6%, and by 2019, it had gone up to over 30%. Now, 2020, 26.2%. So vaping has gone up, although nicotine use with cigarettes has gone down. You can see there's a big trade-off. Big question here, if vaping wasn't present, would this curve have changed? There's no real inflection in the curve when vaping is introduced. The decline in tobacco products is fairly steady, but vaping has substituted and given rise to a different form of nicotine addiction in grade school children. Electronic cigarettes for smoking cessation. Our friends who do Cochrane studies, the Cochrane Library is full of very formal, very conservative, strict analyses of all the literature. So what comes out of the Cochrane study that was published in September of this year, middle of September, moderate certainty evidence that electronic cigarettes with nicotine increase quit rates when compared to nicotine replacement therapy and compared to electronic cigarettes without nicotine. Evidence comparing nicotine with usual care and no treatment suggests benefit, but is less certain. There are problems with effect sizes and problems with variability. Overall, they say that the incidence of severe adverse effects was low across all study arms, and they didn't detect any harm from nicotine e-cigarettes. The longest follow-up was 2 years, and the number of studies was small. Now, what I read from this is there's not enough evidence to make a really clear statement, so they're kind of hedging their bets. But you look at the other evidence that I presented, and in fact, if you look at some medical journal reviews, there are clear incidents of adverse effects in the use of e-cigarettes. Association between alcohol, marijuana, illegal use, and current use of e-cigarettes among youth and young adults in Canada. There was a Canadian Tobacco, Alcohol, and Drugs Survey. Nationally representative survey of e-cigarette use among 15 to 24-year-olds. And because e-cigarettes can be used as an illicit drug delivery system, the authors of this study suggested we need to understand more about the profile of how Canadian youth and young adults are using e-cigarettes. And they want stricter restrictions on public e-cigarette smoking and awareness campaigns talking about the risks of e-cigarette smoking to be implemented. So we move into the topic of the previous paper. Vaping, typically it's about tobacco, but people do vape other substances. And one of these, predominantly, is marijuana in its various forms. So for 12 graders, again, these are kids finishing high school in 2017 to 18, there was a doubling of the use of vaping devices. There was 30% increase, more than 30% increase for the past 12-month use of marijuana via vaping. And there are significant associations between using a vaping device and marijuana and using synthetic cannabinoids from 2016, 2018. So the same trend of upward use of nicotine vaping is seen for cannabis. There's very little attention to be given in the literature to risks of using this drug delivery potential of vaping for illicit drugs. And there are two key papers I'll point you to. One is E-cigarettes, an unintended illicit drug delivery system by Breitbart, and another one that is actually quite detailed and very useful in the Quarterly Journal of Medicine by Blundell and colleagues, The Dark Cloud of Recreational Drugs and Vaping. So the e-cigarettes and unintended illicit drug delivery system, they talk a lot about the technology, how advanced the technology has been used, and they talk about how the vaping technology can be misapplied. There is more information about pharmacodynamics, usual method of administration, doses for toxicity, toxic effects, and evidence of existing use of e-cigarettes. In their review, they talked about both scientific literature and online illicit drug forums. Anybody who works in the area of addiction knows that you can get a lot of information from listening to what users do in a way that's very difficult to capture by normal scientific methods. So a qualitative approach is really useful. These people don't pop up and advertise what they're doing, so you have to have other ways of finding out what's going on. So e-cigarettes are a viable illicit drug delivery system. Going on to recreational drugs and vaping, some information that's come from surveys. Cannabis. 39% of survey responses, this is among medical marijuana users, 39% talking about vaping in the past month, often combined with other forms of drug ingestion, smoking, or from user forums, around 15% of individuals who vape cannabis also use synthetic cannabinoids. Methamphetamine, increased use of vaporization, including e-cigarettes as a new method for administration of methamphetamine. It is present in effective concentrations in vapor from e-cigarettes. And published evidence is small. The main evidence is the narrative gleaned from internet drug forum users indicating use of e-cigarettes, vape pens, and tabletop units for methamphetamine. This is spreading the technology and spreading the word among the community. For MDMA, there's evidence on internet drug forums of users employing vaporization, including e-cigarettes and tabletop vaporizers. In several cases, they talk about converting the drug into free-base form before vaporization. And survey data indicate nearly 12% of electronic vaping users had vaped MDMA, and this is among medical marijuana users. Cathinones, CAT, is a natural substance, and cathinones are stimulants derived from that. There's evidence of e-cigarette use for synthetic cathinones, mainly from illicit drug forums. And one of the comments that comes out from those forums is, you can do drugs more quietly. It's not obvious to people that you're using drugs. If you're using a vaping device, they assume you're using nicotine. And the idea is that drugs like amphetamine and alpha-PVP, as vaporized ingestion, have more rapid onset of effects and a shorter duration of action compared to snorting those chemicals. A convenience survey indicates use of vaping for synthetic cathinones. About 8.5% of users have vaped methadone and 7.1 alpha-PVP. Cocaine is quite interesting that people are using crack cocaine in these vaping devices. About 11% of people reported vaping cocaine powder, around just under 9% crack cocaine, and almost 3/4 of survey responses talked about e-cigarettes as a preferred vaping device. The interesting technical point is the melting point of cocaine hydrochloride is about 200 degrees, and at that temperature cocaine decomposes. Crack cocaine is volatilizable at 100 degrees, and if you go up to 200 degrees, you end up getting some pyrolytic breakdown. Thermolytic degradants for both cocaine and methamphetamine include potential carcinogens, and there are some psychoactive 7.3 of electronic vaping device users who vape fentanyl. That's 2.5 of all these survey respondents. And there are a couple of published papers, the evidence is not strong, that actually provide evidence for acetylfentanyl and 4-fluorofentanyl associated with vaping. One was a death, the other was somebody who was checked, who was intoxicated. Other drugs, use of tryptamine, derivatives, and ketamine. Of all the drugs of abuse surveyed, only gamma-hydroxybutyric acid and MDA were not evident for vaping. And the suggestion is perhaps oral dosing is so well established that that hasn't been done. But we don't know what's going on out there. We don't know what the trend will be. I'm going to end with an interesting point. September the 9th, 2021, Yale Medicine reported, with this very nice picture of all these different vaping devices, reported, will vaping be banned? The FDA was being asked to approve vaping devices, and they delayed their decision. Well, it turns out that on October the 12th, the FDA permitted marketing of e-cigarette products, marking the first authorization of this kind by the agency. And the agency denies applications for flavored products for failing to demonstrate that those products would be appropriate for protection of public health. You have to think about all the pressures the FDA is under. Given the evidence, it's interesting to speculate. Would you, as physicians and scientists, looking at the evidence presented in this talk, would you go forward and make legal vaping devices? Would you think about trends in children? Or would you put a stop on it? And here, not picking on the United States, but looking at the pressures that government is under from private industry. Here is a case where the FDA went, okay, and you can see the knife balance edge of vaping is increasing nicotine use and probably a gateway to smoking for kids. Vaping devices are also devices that can be used for illicit drugs. This is not about legalization of drugs or not. This is about a technology that may or may not have positive effect in terms of the interests of public health. So I was surprised but not surprised by this FDA decision. They can change their mind, but on the balance of evidence, I think this was probably a bit of a political decision. And in the background, you can see from the Mental Health Collective, 55 million vapors by 2021. In Canada and the United States, about 15% of the population is vaping. I have a son who has a nicotine addiction with smoking cigarettes. It's so socially unacceptable to smoke cigarettes, he started vaping. There may be some of you in the audience that do that, because somehow it looks a bit more socially acceptable. But in fact, it has adverse effects on health. And if you're looking to be a role model for young people, this is actually enabling the growth of an addiction. And the very sad change in nicotine use in high school children since people started vaping is really lamentable. So I don't think this, my personal opinion, I don't think this FDA decision was a good one. Anyway, that's a brief run through vaping and new age addiction, and I'll leave you with this very beautiful picture of Lake Louise. Pictures don't always look like the place, but I can tell you the place is better than the picture. I took a visiting professor all the way down to the end where the mountain range is on a long day of hiking, and I never heard so many comments about, taking photographs and videos and just raving about Western Canada and the mountains. So if you can, this is a real destination to go to, and you're all welcome. So thank you very much for your attention today.
Thank you so much, Andy, for this excellent and interesting talk. I was wondering if there are any questions for Andy. Yes, we have a question from Wim van der Brink.
Now I'm in trouble. One of the world's addiction experts is going to ask me a question.
Thanks very much for a great talk. It's always the question whether you think that the glass is half full or half empty. And so if you are a psychiatrist and you know that of your psychotic patients, most of them do not die of the disorder, but they die either of smoking or the medications that they give. So if you have a patient like that, and he didn't respond very well to your varenicline, but he is willing to take vaping, which I think will reduce his health problems dramatically if he would do it. And it's much cheaper than smoking, so he would have some money left. Would you see that? Because you said the Cochrane was rather questionable. I thought it was an extremely positive review of the Cochrane. They're never positive about anything. So if you see this review, I thought it was quite amazing, actually. They were quite positive. So I have it in my armamentarium if I want to treat schizophrenic patients who want to stop with smoking, especially in places where they're not allowed to smoke anymore.
Yeah, Vim,
so would you do that?
Yeah, I think you chose the kind of the key point of difficulty for clinical judgment. I remember when the big anti-tobacco lobby came out to ban smoking in hospitals. And one of my senior colleagues said, one of the few pleasures our schizophrenic patients have who maybe have anhedonia and maybe negative symptoms, many of them smoke, and it's always been a question of whether they're self-medicating, this alpha-7 nicotinic receptor thing. And, you know, wisdom says that cigarettes are so bad that it is not good for people in hospital. With schizophrenia or not, we should be finding another way. But the lesser of two evils is vaping, and I think there are some situations in which you could ethically justify that, and I think you've chosen one of them. The issue there is that for most cases, these are not super young people. I mean, there are early onset schizophrenia cases, or early onset psychosis, but in that population, it's culturally the norm, and it seems to give people some relief. My concern is for the young generation, you know, the grade school students who are likely to pick up the habit, likely to accelerate it, and likely to get primarily the health problems of having chronic nicotine exposure, but also the gateway problem. Comorbidity in psychiatric disorders is a huge problem. Addiction is comorbid in many, many cases. But I cannot disagree with you including vaping for psychotic patients because there's such a drive for them to do that, and the quality of life is super important. The big issue is how do you do that selectively with making sure the message goes out to other people that if you can avoid this, you should.
Like you, I was very amazed about the FDA statement because that's not about the medication, that's about a device for the general population.
Yeah, it's
so
about the
I
industry.
think the FDA should stay out.
It's about the industry. Thank you.
Thanks, guys, for this excellent interaction. I guess we don't have any other questions. Then we are going to go for our next talk. It will be our last talk of today. Herkese merhaba tekrardan.
Hello everyone, once again. I am quite happy to see you, have you here. It is a quite intense day actually. This last talk will be about cannabis once again. And the title is Cannabis for Entertainment, is it right? Not really.
Talk on weed. I didn't know what to feel actually. Should I be honored, or is it because I live in the Netherlands? And I still think that maybe it's something to do that I live in the Netherlands. I know this is a sensitive topic and a very important one, so thank you for elaborating and exploring together with us. And I also realized that it's also a little bit walking on the edge if one starts to find issues about it. Whatever name you give to it, cannabis is still the most used illicit drug, and it has a pretty prevalent place in our society. And so how cannabis is affecting us so powerfully? Before asking that, I would like to know how many of us are smoking, not pot, but cigarettes. Wow. None of us. Great public. Me neither. I have never smoked in my life. So I will try to explain the characteristics and typical features of the Dutch drug policy. It's a bit embarrassing to do that in front of Wim van der Brink. He is the master of it. But I'll do my best. And the policy that has always been tolerant towards the drug use and users. Then I will show you that there are important changes in this policy in the last years, which shifted towards a more restrictive approach. And we will talk about the side effects and conclude if it's really fun. So cannabis, as I said, is the most common substance used by the Dutch adult population, aged between 15 and 64 years, followed by MDMA and cocaine. There's also a gender gap regarding cannabis use, which remains wide. Last year, prevalence of cannabis use among young adults was approximately 1.5 times higher among males than females. One of the principal motivations for the 1976 revised Opium Act was to prevent stigmatization and marginalization of cannabis users, of which a criminal record is often the start, as it may be a barrier for employment or educational opportunities. In comparison to other European nations, arrests and convictions for the use of illegal substances and possession for personal use are very low in the Netherlands. This figure also shows, beyond any doubt, that this aspect of Dutch drug policy has been always successful. Arrests, criminal records for cannabis use or possession are extremely rare in the Netherlands. So if you eat hash or have a weed, then it might take up 2 hours to show up with any effect. So do not take a second bite of that cake. Wait for a while. The effects last 4 to 6 hours, and some studies suggest that some types of marijuana are now stronger than in the past. The Dutch tradition doesn't shy from controversy. The country has a centuries-long history of pragmatic approaches to potentially controversial subjects like euthanasia or use of psychoactive substances. Tolerance and collaboration, despite the differences or lifestyle, are always crucial to the early prosperity of the Netherlands. And during 1960s, 70s, it's changed from a rather closed and segregation society to a more secular, individualized social order. However, the need for pragmatism, tolerance, and dialogue didn't subside, and these qualities remained at the core of Dutch process. As I said, the characteristics are pragmatic, health-oriented, and prevents marginalization and criminalization. And the second basic principle is, instead of investigating in a war on drugs, you'll better focus on protection of public health and keep the risks of drug use as small as possible. Further basic principle that you will better prevent marginalization and criminalization of drugs, because when you send people to jail, they won't come out any better. So how did it work so far? There have been positive developments, which are use of highly addictive drugs remained low, heroin, crack, amphetamines, and there are low rates of infectious diseases among injecting drug users, low death rates among drug users, and coffee shops kept cannabis users away from the hard use. Trends in cannabis use in line with other countries, which is no heavier use, no lengthier using periods. There have been some negative developments as well. Supply of cannabis, which we call the backdoor coffee shops, has been a high priority. there's an ambiguity, which is known as backdoor problem. So it's like you are allowed to buy the milk, but you're not knowing anything about the cow. The anticipated consequences was a significant increase of the criminal organizations' involvement in the cannabis cultivation. But the government didn't feel responsible from the backdoor, and coffee shops' policy became increasingly framed in terms of organized crime and public order. So coffee shops are probably the widest known example of Dutch drug policy. Has anyone seen coffee shops in the Netherlands live? It's something like this. It's very casual. It can be next to a church. It can be next to a school. The Netherlands laws are about as liberal as a nation can hope to attain without full legalization cannabis, actually. So a citizen can possess 5 grams of weed at a time for personal consumption, and then the Dutch weed is not decriminalized, we can say, in that sense. But this means that the police won't go out randomly handcuffing unsuspected smokers. It's still illegal in law book. Back then, one got their weed via a dealer. Apparently, criminalizing and penalizing didn't do the trick. This statistics displays the total number of coffee shops in the Netherlands from 2005 to 2017. In 2013, there were approximately 600 coffee shops in the Netherlands. By 2017, this has increased to roughly 570, and nowadays it's 173 coffee shops in Amsterdam. It's a government-based way of shutting down any coffee shops within 250 meters of a school now, and this has resulted in these numbers. So even though they were tolerated to have a license, they are now having the license from the mayor of the city. And tolerated means that the sale of the cannabis, which is in fact a criminal act, will not be the subject of investigation by the police and will not be prosecuted. Coffee shops are tolerated because they keep cannabis users away, again, from the illegal criminal markets, it's believed. And in the adherence to the tolerance criteria, a coffee shop is not permitted to advertise. There can be no hard drugs, and then the coffee shop causes also no nuisance, no more than 30 grams. In 2012, new restrictive rules were added, finally, to new criteria. Here you see the purchases going down in 2012, but interestingly enough, you will see that outside of the coffee shops going up. So this is an example of a menu from a coffee shop in the Netherlands. It's over the counter, but it's never off the street dealers. Most coffee shops have a weed menu like this, which gives information, usually in English, about the various strains they have available. And alcohol is not permitted in these coffee shops. Sardar Hoca has explained the background very nicely. Cannabis is a plant that grows naturally and has been used within textiles or even traditional Chinese medicine for thousands of years. It's the most commonly used mind-altering drug in the US. It's illegal in some states currently, but there is a game changer nowadays, as Andy has very nicely illustrated the differences. And the THC is the most known of these chemicals as a psychoactive compound. Now, cannabis is made up of 100 different chemicals, but 2 of those chemicals are by far the most interesting and known ones. Those are CBD and THC. And CBD is actually where the most medical properties lie. It's an incredibly fascinating part of the plant with real potential to help the people, seems like. It is non-intoxicating, so it's almost like you can have a bath in it and you can still vape, and then you can even have a smoothie of the CBD and you won't get high. But it will be very costly. So for as interesting and remarkable part of the plant is the CBD, it actually actually makes up the very tiny portion of the commercial market. The real money is being made in the other chemical, and it's the THC part of the psychoactive part of the plant. This Sadr has mentioned the medical utilities. One of my friends mentioned me about his first patients came to his pain polyclinic, and that was a very old lady. She had chronic pain, nothing was helping her, so she wanted to try the medical marijuana. And after a few weeks, she was called by him, "How are you doing?" And the old lady was, "Yeah, my whole life has changed. It's amazing." And then my friend was very surprised, like, "How come? Tell me, did it really eliminate all your pain?" She's like, "No, my pain is horrible. It's still there, but my grandson keeps visiting me every day." So apparently, she was able to get her grandson because there was always weed at home. 2012, Colorado legalized the cannabis and added to what has now become a multi-million-dollar business, global industry of THC. It is the often unseen impacts of the commercial cannabis industry. Good to question those who are getting actually rich of it. I know I'm putting myself in a bit risk talking about the politics of it, but this is so far what I have realized by reading those articles. So the industry groups and corporations, such as the Drug Policy Alliance, Marijuana Policy Project, and so on, they have chased out and helped a lot of small-time growers, which is called 80-20 rule, if you have ever heard of it. It's so simple. It's where 80% of the product is consumed by the 20% of the consumers, and those are the problem users. So they know that it is more than twice as likely to consume THC regularly if one earns under $20,000 a year than those who earn over $50,000 a year. In other words, the poorer you are, the more likely you are to spend your money on their products. It's horrible. It's an unfortunately income, and that it also shows that income and race are correlated, which begs the question about minorities. We often hear that the legalization of marijuana will help to stop the disproportionate incarceration rates among minorities, but is that so? During the same period of the legalization, there was a 29% increase in the arrest of Hispanic kids for weed-related activity, and a 58% increase in the arrest of black kids for weed-related crimes. So actually, people of color are being arrested more than they were prior to commercialization. Another big issue is the school suspension rates. So schools that are predominantly white, that is, they have a minority population of 25% or fewer. In the first full year of data collection, following the commercialization, they had a grand total of 190 drug-related suspends, so almost all of which was THC. When you compare it with the school with the people of color, it's 801. It's almost 7 times higher. My colleagues have talked about. So, I mean, when you look at the literature, you see that it could be harmful in some ways. And I know I could also tell about the benefits of it, and this has been done, so that's why I'm focusing on the harm. It could cause confusion, anxiety, paranoia. Smoke with tobacco can increase the risk of the lung cancer. Regular use has been linked to increased risk of psychotic illness, and in some places to treat side effect of psycholosis and cancer has been done. It could cause attention deficit in students, and there are trials underway to look at epilepsy and HIV. It's the source of NHS. And the long-term effects of marijuana abuse has been found as mood swings, reduced ability to learn, lung infections, inhibited mental development, panic attacks, and memory loss. This is an article from the Duke University, which was conducted for the marijuana use and as the potential possible effects on the teens. And here you can see that there's an average decrease of 8 IQ points. Somehow the whole graph is not there. I can give the references later on. And the immediate side effects of the marijuana abuse. So marijuana-related emergency room admissions increased by 59% from 2006 to 2010, according to the United Nations Office on Drugs and Crime. And some of the immediate effects, again, paranoia, elevated heart rate, overheating, I think we're overheating, it should be, impaired motor function, anxiety, impaired cognition. This is a very nice article. It's the contribution of cannabis use to variation in the incidence of psychiatric disorder across Europe. This was published in Lancet Psychiatry. I fear that we are allowing industry to take advantage of the most challenged among us in order to turn a profit, much like we saw with tobacco and food in the past years. Thank you very much for your attention. Are there any questions? Wim. I'm sweating.
I have actually only one. There's a lot to say about, especially about the 40 study, which I think is a completely unbelievable study. They say that 50% of all the psychotic episodes in Amsterdam is directly related to skunk. If that would be true, we would have much higher incidence rates of schizophrenia in the world than 50 years ago, which we don't. So I think I don't know if it's a crazy study, but the only thing that I missed actually in your presentation is you said, is it fun? And as long as we don't start to understand what the fun is, we can't talk to kids who are using cannabis. And so you said maybe not, but what's the fun?
Yeah, that's an excellent question. I think it's also a very existential question. What is fun? What is fun? It could be considered in the context where you look at fun. Especially if you talk about teens, fun could be hanging out with friends, whereas an elderly person, it can be being with a family. I think it really depends on the age and the context that people are. I think there can be nice studies done by asking those age group, what do you get from this? What do you feel? What is fun for you? And, but I can talk from my point. When I used to live in Amsterdam, when I was smelling cannabis around people walking, it was never fun for me. I'm biased.
Great talk. I don't know if I missed this, but you were talking about the number of people purchasing in coffee shops, and those numbers going down and people purchasing outside. Is that driven by economics? The price is different? Is it driven by not wanting to comply with the rules?
Yeah, thank you for clarifying that question. I thought I told about, but it's the drug policy has changed recently in the Netherlands. So the coffee shops are being closed more, and that was one of the times that it was going down. And then we found out that actually people are then going outside looking for. So actually the consumer stayed the same, the number of, the amount of people who wanted to go there, but they couldn't find a place to go, so they were looking outside to look for it.
That makes sense. So a very personal question. All this stuff about in the Netherlands, the approach has been to try and control and contain things in a way, to be liberal but not to make it legal. Do you think that drugs should be legalized? And you know the examples of countries like Portugal where they just decriminalized it and nothing bad happened. So I wonder what you think.
This is a very good question again. but very difficult to answer. I personally don't believe in banning things. I think the Dutch model so far has been really exemplary. It has worked. I think this how we are doing it in the Netherlands for the harm reduction. I'm very happy as it is, I would say. Thank you. Yeah, I'm looking to now Gültekin Hoca.
I think there is no any other questions. Is there any questions? I can't see the meeting room, so everyone, is there any questions? Can you see?
I cannot see any questions coming.
Okay. I think it was a very important session, and I learned too many valuable informations in this session. And I would like to thank you for your contributions. And I hope to see you face to face. And if you don't have any other questions, then I would like to finish this session and thank you again to all of you.